patient عمره 14 سنة, CB patient accompanied by his mother. تمام, could you please approach this patient and examine him? You knock the door. السلام عليكم, كيف الحال؟ مثلا انت حضرتك والده, انا دكتور عصام وامتحن البورد الليبي, تسمح لي بعد انك نفحص ابو بكر؟
تفضل.
تمام. ابو بكر كيف حالك؟ تمام. بعد انك بنسالك شويه اسئله, هل ابو بكر عنده قدره على المشي والحركه؟
لا لا, يمشي بعكازات.
يمشي بعكازات. تمام, يعني تو حاليا مش حيقدر يمشي.
لا.
تمام. باذن الله. تسمح لي ابو بكر بس اذا كان تساعدني تحي لي جاكيته, تمام, وحذاء لو سمحت. مثلا درت الشيء هذا انت. تمام. So to start with, I can see that this is a 14-year-old child who's sitting. He looks comfortable. He doesn't look distressed. He doesn't look in pain. In his wheelchair, apparently, and as described by his father, that he's walking using a frame. So I will give him the gross motor function classification system of 3. And from the posture that I can see the patient with, so I can see that the patient is keeping both shoulders in internal rotations, both elbows are flexed, forearms are pronated, wrists and hands are in flexion. I can't see any adduction deformity of the thumb. He's sitting in the chair, he's keeping both knees on flexion, he has both ankles in equinus positions. So now I commented about the posture that the patient was in. تمام. تسمح لي بعد انك ابو بكر انك نحرك شويه, تمام. while I'm moving, I need to know. So he's a spastic, so I can see that he's a spastic type. Okay. So he has very limited movement of his elbow, very limited movement of his wrist, very difficulty to extend his fingers. The same finding on the other side. So the patient is keeping his flexion posture on upper extremities. Okay, without any further delay, I would really now go for the lower extremities. So since the patient is sitting, it's quite difficult for me to take him back on a trolley in case you find him in a wheelchair. So I just grab a chair and get closer to the patient. بعد انك تسمح لي اول شيء خلينا نحن كده. في الexam, you need really to accommodate according, خليك very creative. Accommodate according to the situation that you are in. مثلا احنا حاليا ما عندناش trolley to do the examination in. I'm accommodating. تمام. The way to accommodate this, بعد انك حنحاول تساعدني بس خليت رجله الطريقة هذه حطيتها on my thumb. Okay. For now, I'd rather go to examine his equine. So his foot. So the common deformities of the foot in the CBA patients, they either in equinus or calcaneovalgus. Okay? So his equinus, I'm trying to correct his equinus, so it doesn't correct, okay, a knee flexion now although. So I'll try to extend the knee, okay, so the knee doesn't go beyond 20 to 30 degrees. So it moves like 5 to 10 degrees only. And with the knee flexion, it moves more. So this is a positive silver square test. So that means that my contractures in the gastrocnemius. So in order to release this equinus deformity, I need to do a gastrocnemius recession, not tendinoatil. Sometimes it's mixed, where I have to do both. But usually if a positive silver square, so the deformity is up from the gastrocnemia. Okay, I have to repeat the same thing with the other knee, with the other foot in order to finish it. Same issues. So now I can't extend the knee beyond 30 degrees. Okay, his equinus doesn't correct beyond 10 degrees, and it corrects more than 10 degrees difference with the knee flexion. So this is again positive silver square test, and hence I have to approach the patient proximally because the problem is in the knee. Okay, now I'm done with the foot. I have to go to the knee. So for the knee, most of the time, the deformity is a flexion deformity. Some of them, they can come with extension deformity or extension problems. So for the knee, so he's coming in flexion, for example, okay? I will try to correct the knee, okay, while the hip is in flexion, and I will try also to correct the knee while the head on extension in both sides. So, in order to know whether the problem is coming from either the hip or the ankle, I have to move the knee on different positions. I've tried the silver coil, okay, recently, and that didn't really affect the knee as much to the ankle. So the ankle positions, they were the same with the knee. So I don't really need to repeat myself. So that's why I've done it with the hip. So with the hip, so the issues that comes on the knee, they're either hamstring or biceps femoris tightness, okay? In such scenarios, I have different ways or approaches to do. Some of them I can do hamstring release, I can do Z-plasty or lengthening of the biceps femoris. I can also do transfer of the semimembranosus from the tibia, insertion from the tibia to the distal femur. So those are the approaches that I can do the knee in case of flexion issues. Sometimes when they are in extension, so if the knee is already in extension but doesn't really want to flex, okay? Now I have to check it with the hip. So does the knee flex while the hip is on a flexion? Tamam. If it does, and it doesn't while the hip is in extension, that means I have quadriceps femoris tightness, and I have to release the quadriceps or do lengthening or Z-plasty of the quadriceps femoris muscles. I have to repeat the same issues there. Then I go to the hip. The hip, my issues in the hip most of the time is flexion and adduction. Sometimes they're even scissoring. So my flexion most of the time is related to what? To the rectus femoris. I don't examine the flexion until I finish the adduction. Why? Because I have to don't turn those patients too much. Tamam. خليك very gentle to them. So I have to examine for the adductors. Regarding the adductors, I have to do hip adduction, okay? Hip adduction while the knee is extended. Then I have to try the abduction while the knee is flexed, okay? If it is abducting more while the knee is flexed, that means the patient is having adductor tightness. Tamam. In that scenario, you need really to release the adductors. The other scenario is that you need to examine for the hip flexion. The hip flexion, in that scenario, you need to, for example, the patient now is on the wheelchair. So I have to look at the examiner and to the mother. Is there any chance that I can do Ellie test while the patient is prone? If they allow me, I will help the patient gently. I'll put him on the table. I'll put him prone. Then I will do knee extension and knee flexion, and I look for the rectus femoris tightness. In case of rectus femoris tightness, what will happen when I flex the knee? The pelvis will lift up. Tamam. In that scenario, I'm done with the examination of the CP patient. So the mother told me that the patient is ambulating. I keep the ambulation part to the last, okay, in order not to distress the patient. So after I finish this, I look at the examiner and the mother. Do you allow me to ambulate the child? If they allow me, then either I will get the walking aid and supposed to be next to him, or I help him. At least you need really to pretend that you want to do this. Most of the time, the examiner will stop you at that point, and you will go to the discussion part with you. Thank you very much.